The session. Sjogren's syndrome is an often underdiagnosed disease because of its diverse presentations, especially if the patient presents without Zika symptoms. So let's see what the speakers have to tell about this. For discussion, I invite the chairpersons, Dr. Ramya J. and Dr. Nilesh Nolka, over to the dais. Dr. Ramya J. is Associate Professor, St. John's Medical College, Bangalore, and Dr. Nilesh Nolka is Consultant Rheumatologist at Wockhardt Hospital, Mumbai. I also invite the speakers, Dr. Sandhya P. and Dr. Kunal Chandwar, onto the dais. Please come out to the dais. A keynote lecture will be by Dr. Hal Schofield. He will be joining us online. Recorded lecture will be available. Let's start the session.
Who's Ramya?
Dr. Ramya.
Good morning, everyone. I'm sorry that I couldn't join you in person today at your meeting. I had lots of trouble, but I was planning to attend. But I'd like to tell you about the diagnosis of Sjogren's and a new phenotype of Sjogren's that we think we've identified in just the next few minutes. Of course, autoimmune diseases are common when you add them all together. There's at least 80 diseases we think of as autoimmune that affect about 6 to 8% of the population. And of course, they're more common among young adults and much more common among women. And one interesting way to think about it is that autoimmune diseases are actually a very common cause of disability and inability to work and do what you need to do among especially young women. Henrik Sjogren'S described Sjogren's syndrome in his doctoral thesis in 1933 and described 19 patients. Of course, Sjogren's syndrome has exocrine gland dysfunction, that is lacrimal and salivary gland dysfunction, and it has autoimmunity in the form of serum antibodies such as anti-Rho and anti-La. Patients also have rheumatoid factor, cryoglobulins, but these patients also have extraglandular manifestations. And so Sjogren's is this chronic autoimmune disease. Here you see a lymphocytic infiltration in the salivary gland of a patient, and that is really a key feature of the disease. The other key feature is the autoantibodies, anti-Rho and anti-La. There are research evaluation is a different entity than clinical evaluation, and for research evaluation, there are criteria. For clinical evaluation, for clinical diagnosis, there's really expert opinion. And so what are the general features of Sjogren's? Of course, there's the xerostomia, the xerophthalmia, the Zika symptoms. There's autoimmunity, the lymphocytic infiltration, autoantibodies, and then there are the extraglandular manifestations such as vasculitis, arthritis, pulmonary disease, kidney disease like RTA, but also a systemic manifestation that's very common and very troubling to the patients is fatigue, which really does not go along with any laboratory feature of Sjogren's. The female ratio in Sjogren's, female-male ratios is at least 9 to 1. It might be more like 15 to 1. I earlier said autoimmune diseases are of young adult women, but in fact, the average age onset of Sjogren's is much higher than the average rate of many other autoimmune diseases. However, when you talk carefully with these patients, many of them have been sick for many years. About a third of patients with Sjogren's have some other autoimmune disease in their family. and it is or underdiagnosed quite frequently, requires multiple specialties. Patients are kicking around for many years without a diagnosis. We found several years ago, if you had a positive ANA and you had Sjogren's, you were likely to be misdiagnosed with lupus in the past. If you have positive rheumatoid factor, you were much more likely to be misdiagnosed as rheumatoid arthritis in the past. So it's hard to diagnose Sjogren's. It's hard to get all these specialties together. And there we see just the prevalence of a number of autoimmune diseases, and primary Sjogren's is in there as quite prevalent, more common than Crohn's disease, systemic lupus, multiple sclerosis. So it is a common illness in the population. And so there are these extra salivary manifestations that go along with the presence of anti-Ro, and there you see a number of them listed. We're all familiar with those, perhaps. In long-term follow-up of 74 patients in the United Kingdom some years ago now, 10-year follow-up though, really only the anti-Ro, anti-La positive patients developed systemic complications. So it is strongly related to having the antibodies. And one of the the worst type complication, the most feared complication of Sjogren's is lymphoma, and you see there that primary Sjogren's and secondary Sjogren's have a markedly increased risk of lymphoma compared to control populations, and increased compared to other autoimmune diseases you see there, like rheumatoid arthritis, scleroderma, lupus. And so there's quite a risk of lymphoma, although most of the time this is mild lymphoma that can be treated relatively benignly, and most people are cured. And there's the risk there. So, and you also have this primary versus secondary Sjogren's. Primary Sjogren's is with no other autoimmune disease. Secondary Sjogren's is present with also at the same time as some of these diseases you see here. There's lots of movement in the field that perhaps primary secondary is not a very good way to divide the disease. That perhaps these should, instead of secondary, we should use some term like overlapping or combined, as why is Sjogren's secondary and the others are primary? Sjogren's may in fact be the disease that gives people the most trouble. And so maybe this is some sort of artificial distinction that is not very important. But classification of Sjogren's for research purposes is different than diagnosis. The newest criteria that were published simultaneously in the Annals of Rheumatic Disease and Arthritis and Rheumatology, you have to have the suspicion of Sjogren's somehow to get in the system. You have SICA, peripheral neuropathy, RTA, arthritis, something's going on. Then either anti-Ro or a focus score in your salivary gland on pathological examination of your salivary gland are 3 points each, and then ocular staining abnormalities, abnormal Schirmer's test, abnormal salivary flow, and that's whole salivary, unstimulated whole salivary flow are all worth 1 point, and you need 4 points to be classified as Sjogren's. And that means, of course, you have to have one of either the antibodies or the focus score. And but I think the same is true in clinical diagnosis of Sjogren's, which is really fundamentally simple. It's expert opinion only. You can't be diagnosed by the classification criteria. But really, to be called Sjogren's, clinically, we would want to see either evidence of autoimmunity with autoantibodies or a biopsy that shows lymphocytic infiltrate. If you don't have either one of those, then we're highly unlikely to call you Sjogren's. And so, as I said, the diagnosis really, clinical diagnosis requires autoantibodies or the biopsy, but the biopsy is hard to obtain, and it's also hard to obtain the proper reading even if you do get a biopsy. But we do get biopsies routinely. We run a clinic for Sjogren's syndrome or a clinic for evaluation of patients with SICA. In a single clinic site, in a single visit, patients get medical rheumatological examination either by me or Astrid Rasmussen. They get ophthalmological evaluation and a dental exam that includes a minor salivary biopsy in almost every patient. Everyone's consented for research. We store samples. We've evaluated about 1,200 subjects, who perhaps 40 of whom meet the research classification criteria in our clinic. So we have a large number of patients in this clinic. And we made this initial observation some time ago now. We purified antibody secreting cells, B cells, from the biopsies. PCR amplified their immunoglobulin light chain heavy chain heavy chains, expressed those in 293 cells, and therefore we made human monoclonal antibodies. And many of these antibodies, and we know these antibodies existed in life because we got them from a single B cell that was secreting antibody. Many of these had anti-Rho, anti-La, or rheumatoid factor activity, but that included some subjects who did not have a given specificity in their serum. So maybe we found an anti-Rho producing cell in their salivary gland, but there was no anti-Rho in their serum. And we got interested in that aspect of it, and we wondered whether those patients might have these antibodies in their saliva. And there's already data that antibodies are in saliva. And we took 100 Sjogren's disease patients and 100 non-Sjogren's Zika patients who do not meet the research classification criteria. And in general, those patients are not going to have anti-Rho, and they don't have a focus score greater than 1, because if they had those, they would have met the criteria. And we did a ELISA test on saliva looking for anti-Rho, anti-La, and rheumatoid factor. And mostly I'm going to discuss with you the anti-Rho results. In fact, we found that there was a large number of patients who were serum anti-Rho negative, but salivary anti-Rho positive. That was 29 of the non-Sjogren's Zika patients and 24 of the Sjogren's disease patients. And that showed graphically here, 29 of 100 non-Sjogren's Zika patients had, shown in red there, had antibody in their saliva, but not in their serum. And then we looked at the clinical characteristics of those patients. So I'll give you just a little flavor of that data. Here's the Schirmer's test, the percent positive. Here are the subjects who, non-Sjogren's Zika patients who didn't have salivary antibody. That's all of these, right? And here's in the dark black is the non-Sjogren's Zika patients, people who did not meet the usual criteria, but had antibody in their saliva. They're no different from the Sjogren's patients who met the criteria. And these are these same data where you see every individual data point. This was also true for ocular staining. It was true for whole salivary flow over time salivary flow, and it was also true for the extraglandular manifestation disease. These patients with the salivary anti-Rho looked like Sjogren's patients. So we think we've identified a new phenotype of the disease, that patients that have Zika, they have objective eye and mouth findings, they have extrasalivary gland manifestations, and they have salivary anti-Rho. And we would have, if salivary anti-Rho counted in the classification criteria, we would have, for research purposes, we would have classified another 29 individuals, a third, almost 30% of our non-Sjogren's Zika patients who did not meet the research classification criteria. So we think this is a new phenotype of the disease, of this common disease, and salivary antibodies may need to be included in our clinical evaluation of these patients in the future. I think the question is it, from a research standpoint and from a clinical standpoint, is this a stable phenotype? Will these patients continue to look like this with salivary antibodies, or will they acquire serum antibodies, or perhaps they'll even get well? But we need to follow them over a long period of time to see what their phenotype is. And I'm happy to stop right there and try to ask any questions, because I'm going to be on in this session live. Thank you.
Thank you. Dr. Hall was kind enough to give this virtual lecture. I'll ask Dr. Sandhya to go ahead with her session. Thank you. So Dr. Sandhya is a consultant rheumatologist in St. Stephen's, Delhi, and she'll be speaking on renal tubular acidosis in Sjogren's syndrome.
Good morning all. So let us get straight into the topic. Can you please help me? It's not moving.
Can somebody from the team help her with the slides?
Okay, let us get straight into the topic. So this would be the outline of my talk. Couple of slides on background of Sjogren's syndrome and renal tubular acidosis, and then I would like to focus on the literature review of 440 case reports of Sjogren's syndrome and RTN published literature, focusing on demography, clinical and criteria features, renal and non-renal features. Now, as Professor Hal Schofield already mentioned, there are two very important aspects to diagnosis of Sjogren's syndrome. One is the presence of antibody, and second is presence of lymphocytic infiltration of exocrine glands. SICA is the most well-known symptom of Sjogren's syndrome. It may not be the most common. There are distinctive extraglandular features. RTA is one such manifestation. RTA in Sjogren's syndrome was first described in 1965. Now, what is the underlying pathology of RTA in Sjogren's syndrome? This is characterized by tubulointerstitial nephritis. There are lymphocytes, T more than B cells, plasma cells and monocytes infiltrating the renal interstitium. Tubular atrophy and interstitial fibrosis are present. Now, if you look carefully at the picture, this infiltration is very much similar to that seen in the salivary glands. So, with increasing reports of cases of RT in Sjogren's syndrome and this understanding that the lymphocytic infiltration in renal interstitium is similar to that seen in salivary gland, RT was recognized as an inherent component of Sjogren's syndrome. Now, let us look at the data that is available from retrospective cohorts of Sjogren's syndrome across the world. Now, this gives us an idea of frequency of RTA in different parts of the world. In an early Chinese study, the frequency of RTA was 16.7%. In a more recent study, it is 6%. In an Indian study, this is from CMC Vellore, 8.1%, UK 3.9%. EULAR did a 2015 systematic review in which the frequency of RTA was 9.3%. The largest collection of renal tubular acidosis is from China. So this is a Chinese study reported in 2008 Journal of Rheumatology. They looked at 130 patients with renal Sjogren's, of which 95 had renal tubular acidosis. Now, other large case series reporting exclusively on Sjogren's syndrome and renal tubular acidosis, this N is 52 is from SWIMS in Tirupati, and all the large series numbering more than 10 case reports are all from India. So, despite this literature, a comprehensive description of the clinical features are lacking. And interestingly, for specialists other than rheumatology, Sjogren's syndrome renal tubular acidosis is considered an enigma, which may be a good thing because they continue to publish the single unique case reports and small series. And representation in this is a very unique thing because the representation in case reports possibly outnumber the data that is available in cohorts. And this was the inspiration to systematically compile and analyze all case reports and series of Sjogren's syndrome renal tubular acidosis and describe the characteristic of Sjogren's patients with RTA. So a systematic search of relevant publications in all languages were undertaken. So there is no money, so only the free databases were looked at, PubMed, Google Scholar, JStage and CoreaMed. And the time period is from inception of databases, that is 1960s to December 2021. These were the search terms that were used: Sjogren's syndrome and renal tubular acidosis or hypokalemic paralysis or interstitial nephritis or osteomalacia. Foreign language publications were translated using Google Lens, Google Translate and DeepL Translate. Now, coming to the inclusion criteria and definitions that were used. So, a case report was included only if data pertaining to characteristic of renal tubular acidosis and diagnosis of Sjogren's syndrome were available. And for diagnosis of Sjogren's syndrome, as Professor Hal mentioned, the gold standard is Fission diagnosis. So, the Fission diagnosis of Sjogren's syndrome was accepted if this was supported by either the presence of a positive antibody or histopathological positivity. Now, I also looked at how many of these patients fulfilled the ACR-EULAR 2016 classification criteria. However, it would be unfair to use this classification criteria for patients who were reported in the previous years. So, to make it a level playing field, I have slightly modified this criteria, and in addition to Ocular staining score, that is item 3 of this criteria, rose Bengal staining has also been included. This is because rose Bengal staining was used previously. And similarly, in addition to unstimulated whole salivary flow, that is item 5 of the criteria, xylography or scintigraphy, which was used in earlier years, was included. Now, coming to definitions used for renal tubular acidosis, we know that both distal and proximal RTA are characterized by hyperchloremic non-anion gap metabolic acidosis. Distal RTA is characterized by urinary pH more than 5.5, whereas proximal RTA is characterized by urine pH less than 5.5. In case this was not mentioned, looked at other additional findings to support the diagnosis of distal or proximal. For example, positive acid loading test, positive urine anion gap, presence of nephrocalcinosis, hypocitraturia, hypercalciuria, and fractional excretion of bicarbonate less than 5% supports the diagnosis of distal RTA. Proximal RTA is supported by fractional excretion of bicarbonate more than 15% and presence of Fanconi syndrome. Now, this is the schematic summarizing the curation of publications. The unique publications identified from different databases, duplicates were removed, total of 560 abstracts were screened, 200 studies were excluded, and finally there were 360 publications, and from this 360 publications there was information on 440 patients with both Sjogren's syndrome and renal tubular acidosis. There were 102 non-English language case reports, mostly Japanese, French, Korean, Chinese, Spanish, Turkish, and the remaining as listed. Now, this is the geographic distribution of 440 published cases. As can be seen here, the most number of cases come from India, and China is 30. So, I am no way suggesting that India has more cases than China. I could not access the Chinese database, and China has so many cases, they would not be reporting individual case reports. Having said that, what can be seen in this map is that the majority of cases of Sjogren's syndrome, renal tubular acidosis, are from Asia, 64%, though it is also reported from across the world. And I also looked at the departments reporting these cases. Number 1, medicine, followed by nephrology, rheumatology, endo, and neuro. Okay, coming to the results, other results. So, first the demography. The median age of these patients was 37. If you remember from Professor Hall's talk, the median age of onset of Sjogren's syndrome, they have said 50 to 60. In India, we have shown that the diagnosis proceeds by a decade. So that is 40 years, but you can see this age is even lesser, and ranging from 6 to 78. So as young as 6-year-old has Sjogren's syndrome with renal tubular acidosis. 24 patients were less than 16 years, that is 5.5%, and close to 6% patients were greater than 65 years. Women contributed 95.5%, which is expected. 11 were pregnant at the time of diagnosis of Sjogren's syndrome with renal tubular acidosis. Concurrent autoimmune disease seen in these patients were lupus in 9, scleroderma in 3, rheumatoid arthritis in 2, mixed connective tissue disease in 1. And talking about the criteria features of Sjogren's syndrome, ocular or oral Zika symptoms was reported in 63.7% only. But if you look at the objective testing, positive ocular testing was seen in 77.3%, positive oral test in 96%. Please look at the denominator here. Positive oral tests were done only in 128. That is a very small percentage. This was the least performed test, but you can see the high yield in oral testing. That is 123 out of 128, that is 96%. Anti-SSA antibody positive is 93.9, anti-SSB in 78.6, and positive minor salivary gland biopsy in 91.8. So what I want to emphasize is that even when they do not have very obvious Zika symptoms, there is high percentage of objective testing, so there should be no doubt regarding the diagnosis of Sjogren's syndrome in these patients. And not surprising that only 7.7% had a prior diagnosis of Sjogren's, because these patients would not have sought medical attention for their very subtle Zika symptoms, which was easily elicitable in history. Now, looking at the criteria, ACG criteria was fulfilled only by 54.5% patients, ACR ULR with modification in 81.4%, and most of these people, and if you look at why they have not fulfilled criteria, because the evaluation for criteria features were incomplete in all 82 patients not fulfilling the criteria, and of these 82 patients, minor salivary gland biopsy was not done in 74, and evaluation for Zika signs was lacking in 90. Now, if you look at the frequency of presenting complaints of RTA, the most common presenting complaint is hypokalemic paralysis. This was seen in 280 patients, and 110 patients had to suffer multiple episodes of hypokalemic paralysis before the diagnosis could be made. So, what I suggest is that the hypokalemic paralysis patients are not going to come to rheumatologists. They would be seen by our colleagues. We need to take the phone and call them and tell that if they see hypokalemic paralysis, all patients need to be evaluated for RTA, and if there is RTA, they need to be evaluated for Sjogren's syndrome. I am not suggesting all patients with hypokalemic paralysis have RTA, but there could be a significant percentage that could have a diagnosis of Sjogren's RTA, and this would be an opportunity to diagnose Sjogren's syndrome, renal tubular acidosis. There are a lot of other features which are probably non-specific and may not be worthwhile investing detailed evaluation. Now, talking about the frequency and types of RTA and complications, type 1 was the most common, 387, type 2 in 8, both type 1 and 2 were found in 38, hyperkalemic in 3, Fanconi syndrome in 45, renal biopsy showed tubulointerstitial nephritis in 142 out of 152 patients in whom the biopsy was done. Now, talking about the other renal features, low EGFR was found in 45.4%, proteinuria in 64.7%, nephrocalcinosis and stones in 30+, osteomalacia in 59%, and nephrogenic diabetes insipidus was described in 21 patients. Now, the other point I would like to emphasize in this slide is that if you look at the denominator, it appears that all renal tubular acidosis patients are not evaluated for all the other complications. So, this is another message which I would say, when we see a patient with Sjogren's syndrome, renal tubular acidosis, we should look for all the different renal aspects. Now, talking about the non-renal Sjogren's syndrome features seen in this population, parotitis was seen in 43, purpura in 30, neurological involvement in 20, liver involvement in 16, pancreatitis in 11, lung in 13, leukopenia, thrombocytopenia in 11 and 5 respectively. So, I also came across something very unique. Central pontine myelolysis or osmotic demyelination syndrome was overrepresented, and it is not described in literature as a characteristic feature of either Sjogren's or renal tubular acidosis. So, I have along with Japanese co-authors, we have written a paper on this, and this is the abstract is submitted at Iracon. It is poster number 114 for those who are interested. Now, talking about the etiology for Sjogren's syndrome, renal tubular acidosis, we know that usually in all autoimmune disease, we consider either environmental factors or genetic factors. Now, because all these case reports are from Asia, most people from the West tend to think that this is because of oriental medicine or the herbs that our patients take. If that be the case, we should have rheumatoid arthritis and lupus patients presenting with RTA, not Sjogren's syndrome. So, if in this case reports I have looked at, if there was any mention about these. So, what I can, only 2 people have reported, and if you look at the genetic aspect, I found this very interesting. In 4 families, in 440 case reports, there were other members who had renal tubular acidosis. And then the case reports which I have not included in the study, also I looked at further, and there are 2 families in a prospective study from India and 3 reports from Japan, which again has family history of Sjogren's syndrome with renal tubular acidosis. Now, case report comes at the lowest base of our evidence pyramid, and I know there are a lot of limitations in this research. The literature search, publication bias, single author review bias, and because it is spanning over a long time period, different criteria you use, different specialties, so there is a lot of heterogeneity. But I think we can make some conclusions. There is younger median age, but this condition is seen in extremes of age as well. Subclinical sicker features, but objective features with high positivity. RTA is one of the earliest manifestations of Sjogren's syndrome. Hypokalemic paralysis should be considered an opportunity for early diagnosis, mostly distal, but it could also be because proximal dysfunction is not evaluated often. High percentage of proteinuria, low EGFR, and nephrocalcinosis calculus, osteomalacia, possibly these are evaluated infrequently. So, I have published this. This has been accepted for publication in IGRD. So please consider this as my job application. I would like to collaborate with everyone to put together data on Sjogren's syndrome, renal tubular acidosis. If anybody sees any cases, I would really appreciate if you would email me. Thank you so much.
Thank you, Dr. Sandhya. I think it's one of the most comprehensive literature review on renal tubular acidosis, and this is data we should cherish and use, and I think we should start referring all these patients, at least the data, to Dr. Sandhya. I think that will be the takeaway message here. I'll ask Dr. Kunal to take ahead the session, and we'll take questions at the end of the session after Dr. Ramya gives us the summary. Thank you. So, Dr. Kunal will be speaking or will be highlighting the big doubt, how to suspect Sjogren's syndromes in absence of Zika complaints. Kunal is a lecturer in Department of KGMU, Lucknow, and we look forward to his session. Thank you.
Just a minor revision, I've been shifted to SGPGI as an assistant professor. A very good day to one and all, and I'm Dr. Kunal Chanwar, and I'll be discussing regarding how to suspect Sjogren's syndrome in absence of Zika complaints. So first things first, Zika might not present directly with those classical manifestations of oral and ocular dryness. It can present with varied manifestations including dysphagia, difficulty in swallowing, persistent hoarseness, pruritus in outer ear and inner ear canal, chronic non-productive cough, cutaneous dryness, dyspareunia, and vaginal pruritus. So patient might not complain of the classical Zika symptoms when they come to you. You need to ask them varied manifestations if they have any. Regarding systemic extraglandular manifestations of Sjogren's syndrome, in India, what has been found very commonly are the articular manifestations, the neuro-Sjogren's manifestations, and the nephrological manifestations as mentioned just now. And these manifestations have been shown to present much earlier than the classical Zika symptoms do. How common are Zika symptoms? So in large series from India, Asia and outside, dry eyes and dry mouths are quite common, but these are cross-sectional studies, and most patients that have been included in these studies do satisfy the classification criteria. Hence, the proportion of dry eye and dry mouth is much more common. How does Sjogren present? So in the Indian studies that I could access, arthralgia and chronic non-deforming arthritis is the commonest presentation. It can range from 50 to 60%. Very less patients voluntarily complain of dry eye or dry mouth. It is only about 10%. About 5% patients present with hypokalemic periodic paralysis, and chronic pain syndrome is another common complaint. Now, when we talk about extraglandular manifestation, these are known to appear at least 10 years earlier than the Zika symptoms, and only 60% of patients who have extraglandular manifestations had Zika, and 60% only presented with extraglandular manifestation. Asian patients, the most common extraglandular domain are pulmonary, renal, and hematological. And in absence of Zika symptoms, even rheumatologists could make an initial clinical impression of primary Sjogren's in only 66% of cases. Again, in another study, South Asian patients presented with chronic, mild, non-deforming musculoskeletal complaints and hypokalemic periodic paralysis, and these patients should be suspected for primary Sjogren's. Now, can ultrasound help? So, when you do a salivary gland ultrasound, there are multiple abnormalities that can be seen. The parenchymal echogenicity can be different. This is usually compared with that of the thyroid gland, and an abnormal echogenicity can be reported. The gland can be grossly inhomogeneous. You can see multiple hypoechogenic areas and hyperechogenic reflections. and the clarity of salivary gland borders, especially the posterior borders, may be unclear. These parameters are included in a score termed as the Hoseva score, and that ranges from 0 to 48. A score greater than 17 is highly suggestive of Sjogren's. There's another score that includes only the homogeneity section and the hypoechogenic areas, and that is called as the Omerac score. Now, how does salivary gland ultrasound help us? So it improves the sensitivity of the ACR-EULA criteria from about 86% to 93%, and salivary gland ultrasound has the ability to replace the minor criteria in the ACR-EULA criteria. So if you replace salivary gland ultrasound for minor label gland biopsy and autoantibodies, both the sensitivity reduces, but if you replace it for ocular staining score, Schirmer's test, or unstimulated salivary flow test, it actually remains the same as the original ACR-EULA criteria. So how do you utilize ultrasound for diagnosing primary Sjogren's? So the first step is you perform an ultrasound. If it is grossly abnormal, you could directly go for either a minor salivary gland biopsy or autoantibody, and if they're positive, you might make a diagnosis of primary Sjogren's syndrome. If the ultrasound is negative, they suggest you could add elastography of the salivary glands, and if the elastography score is quite high, this again has a strong diagnostic probability. If the ultrasound is negative and you still suspect it to be primary Sjogren's, you could do the minor salivary gland biopsy and the autoantibodies, and if both of them are positive or one or two is positive, you can further suspect them on the base of the criteria. So I end here and request Ramya ma'am for her expert comments.
Thank you, Kunal. Dr. Ramya will give some expert comment on the same, and then the floor will be open for questions.
When I joined as resident in CMC Value, Dr. Sandhya was the one who first introduced me to this concept of extra glandular manifestations of Sjogren's presenting with absence of Sicca symptoms. So from that time on, we have the inclusion of any of the ESSDI manifestation as an inclusion to consider for classification into primary Sjogren's syndrome. As already discussed, around 20% of patients with Sjogren's do not have Sicca symptoms. It varies from series to series, and in some series it is as high as 40 to 50%. So subjective Sicca is well known to be less in systemic feature predominant presentations of Sjogren's, and it is known to occur at as late as 10 to 12 years after the initial presentation of the extraglandular manifestation. So we need to be aware of all the manifestations which are involved in the ESSDI before we consider. Most of these anyway will be evaluated by autoantibody. As previously discussed, these extraglandular manifestations have a high association with autoantibody, so that will give us a clue. And objective evidence of glandular inflammation may be present in the absence of subjective Sicca. Thank you.
Thank you, Dr. Ramya. The floor is open for questions.
Very elegant work, Rohini Handa from New Delhi. There are two things, Sandhya, I wanted to check about. One is you mentioned a database, J-Stage or something. I was not aware about CoreaMed, and there was one more database which is not very commonly searched. Could you tell us something more about that? And the other is conversely, people with impressive Sicca features and no objective ocular manifestations. What we find is there are some people who have autoantibodies, have impressive Sicca features, but when you do objective measurements of the eye, they are not so impressive. In fact, they may be normal also. Your comments on that?
Thank you so much, sir. So the first question regarding the database, I intentionally wanted to search into the Asian database because I find that the data from the Asian countries are underrepresented. So it gives the feeling, because we always look at the Western literature, it gives the feeling that this is not very common. And even when patients, doctors across the world are reporting Sjogren's syndrome RTA, there is no reference made of all these Asian publications. The Japanese have done excellent work in 1980s. Unfortunately, it's in Japanese language. So when you look at it, so everybody, you can see that every year there are 10 cases, at least there are 10 case reports of Sjogren's RTA, and they go by saying that this is very unique. It is not unique. There is so much of data that is available. So intentionally, I wanted to look at all the Asian database. So KoreaMed and JStage are freely available. But unfortunately, like I said, I want to search Chinese also. Chinese is not freely available. That is why I have looked at those two databases.
Are they in English, or how do we access them?
Sir, some of the JStage publications are in PubMed as well, but all you can go to jstage.org and you can search there. So KoreaMed also, you can go to koreamed.org and you can search. And in case you want any paper, if you request, they are so very prompt, they may reply back with the paper. And sir, regarding the other question that you asked, so the correlation between objective and the subjective features are not good. This is very well known. And the lymphocytic infiltration, you can have intense lymphocytic infiltration and patient may not complain of Zika symptoms. So I think that is, has been seen in previous studies also.
Madam, I am Dr. Archibald from Hyderabad. Madam, this renal tubular cirrhosis commonly encountered. One is main pathology, tubular interstitial disease of kidney. The most common is NSAIDs. Whereas in rheumatology, we see primary Sjogren's syndrome as secondary. Sometimes RA, sometimes SLE, sometimes scleroderma. In systemic diseases, either primary or secondary, is the cyclophosphamide changing the natural history? There is some data, some giving cyclophosphamide or steroid sparing drug, some are not giving. Is there any data showing cyclophosphamide or MMF going to change the natural history of the disease?
Sir, just to clarify, sir, the question is whether cyclophosphamide changes natural history of Sjogren's renal tubular acidosis?
Yes, madam.
Yeah. Sir, the data on treatment aspects in Sjogren's renal tubular acidosis is very heterogeneous. There are no RCTs that are available. So some studies show that there is good response to treatment with immunosuppression, whereas other studies do not show. And so my take on this is, unlike lupus nephritis, where you have glomerulonephritis and there is lot of drama, you start treating pulsing, you get to see immediate improvement. Okay, so in Sjogren's renal tubular acidosis, which is characterized by lymphocytic infiltration, so this will not give that dramatic result as glomerulonephritis. Yes. So if you need to get rid of that lymphocytic infiltration, you have to treat for years together. So that is why we may not see good results instantaneously. Just to make a point, so rituximab we know has not worked in many of the trials in Sjogren's syndrome. But if you look at trials or the studies where rituximab has worked, what I found is that they have given rituximab persistently for 4 years. Every 6 months they have given for 4 years, and at the end of it they saw that they did repeat lip biopsy and they saw that the infiltrate started receding. There was change in manifest. So what I feel is, treating Sjogren's syndrome, we need to be more patient, more persistent. And one more example in cases, there is a case report, 2017 Oxford Rheumatology by Schindler et al. So what they have done is, they had a very bad patient with Sjogren's renal tubular acidosis. So the patient had multiple renal stones, underwent multiple surgeries and persistent hypokalemic paralysis, presented with severe acidosis, low EGFR. They gave steroids, aerosol, and it didn't work. Then they gave rituximab, just like in the previous study I mentioned, every 6 monthly for 4 years. And it is so difficult to believe, but RTA resolved, so much so that they could discontinue alkali and potassium. There were no renal stones henceforth, EGFR improved. So I think patience, persistence and would change and immunosuppression, I think, would be of benefit. And there is a wide spectrum of tubular interstitial. All the tubular interstitial nephritis in RT are not the same. We generally feel TIN is benign. It is not benign. It is just that you don't see dramatic response, so it gives us the feeling that whether you treat or not, it doesn't make any difference. So my take is RTA patients who have just mild electrolyte imbalance, and if creatinine is normal, no proteinuria, ESSDI is 0, I mean, you don't have significant other extragranular involvement, we can treat symptomatically. But if you have all the other features, I feel they should be treated with immunosuppression.
Madam, there again, there's some, especially in Italy, data coming, suppression and maintenance. They have given cyclophosphamide rituximab, that is regular pulse like HLE, then gone for maintenance either MMF or azathioprine. It is followed nearly almost 12 years. That data is very encouraging, madam.
Sir, are you talking about whether we should maintain after induction?
Yeah, induction.
But
because
I think, do we have this kind of regimen where we have an induction and maintenance?
No, we do not have this kind of regimen for Sjogren's renal tubular acidosis. Unfortunately, there is not much of data, but there are case reports, like limited case reports where mycophenolate has worked. This is published from UK. There are 12 case reports where they have treated Sjogren's syndrome renal tubular acidosis with mycophenolate, and it has shown improvement.
Yeah, thank you, madam.
I am Dr. Shiv Prasad from Mysore. I just wanted to know about what is your take on renal biopsy in these cases as diagnostic or prognostic or in whatever the way it is. And the second thing is, yes, we are discussing about the treatment aspect. What would you suggest to start on first other than steroids?
Okay, so regarding renal biopsy, what I would feel is that if you have severe electrolyte imbalance, increased creatinine, proteinuria, and if you have any suspicion of glomerular involvement, then renal biopsy must be done. And I think most of the times this decision is not in our hands. We have to convince our nephrology colleagues. So that is regarding the renal biopsy. And regarding the treatment, if there is evidence of tubular, it actually makes a difference. If you can see, so as the severity of Sjogren's syndrome increases, what you can see is you can find lymphoid structures, you can see germinal centers. This is the case with salivary gland. It is, like I said, there is a close parallel. That is the case with renal biopsy also. So if you see that infiltrates, then you know that you need to treat aggressively with immunosuppression. Now, since you have asked about treatment, giving very high dose steroids may not be a good option in these patients because they have severe electrolyte imbalance. Like if in a patient with severe hypokalemia, giving high dose steroids may be a little bit tricky. The other thing is many of these patients have osteomalacia. The bones are not good. So what I think is rituximab may be a better option, number one. Second, if you look at the recent data from, so like I mentioned in the answer to the previous question, when you give rituximab, what they found is it has taken 4 years to show that improvement. But if you look at rituximab, belimumab, the initial trials which are available, the phase 2 data. So when you give rituximab in combination with belimumab, what rituximab does in 4 years, this combination of rituximab and belimumab achieves in 6 months. So I think once we have that, that will be a game changer. And even more encouraging is the results of ianalumab. So I think they are doing the phase 3 trial in India. They will be starting soon. So ianalumab is a BAF antagonist, and the results in that are also great. They could achieve in 6 months the what I said, the decrease in lymphoid infiltrates.
We'll take one last question.
So I am Dr. Deepak Gautam from IMSBHU Varanasi. My question is to Dr. Sandhya ma'am. Can you anticipate some reason regarding non-reporting of type 1 RTA or any RTA from nephrology, specialty of nephrology? What you depicted, maximum reports were from medicine, followed by neurology and endocrinology. Can there be any reason for nephrologists not reporting the RTA in? And second question, apart from that, what would be the best screening test? Only ABG? Because if the percentage of type 1 RTA and others also is so high in Sjogren's, what should be the best screening test when we suspect Sjogren's, whether it ABG or tests like NH4CL, etc.? And then should we, okay, then you explain and then I'll ask one more last question.
So, regarding hypokalemic paralysis, because patients who come with paralysis, it depends on the hospital setting where we are working. Like where I work currently.
No, I'm not asking about paralysis, not hypokalemic paralysis. I am asking about type 1 RTA, tubular acidosis, renal tubular acidosis. If that is so high in Sjogren's, then why it is not being reported from nephrology?
Yeah, exactly. That is my point. So most of these patients I have shown present with hypokalemic paralysis.
Okay.
Okay, the presenting patients will not come saying I have RTA. So the presenting manifestation is hypokalemic paralysis. So that is the problem with the entire diagnosis. That's exactly what I'm trying to say. So if patient with hypokalemic paralysis come, if you have a patient with paralysis in your emergency, who would be taking care? Who would be called to see the patient? Not the nephrologist, right? So either medicine or neurology, it depends on where you're working.
I got it. Okay, and do you recommend any treatment apart from
Sir,
treatment
can we take this discussion forward?
Sure.
Yeah, please. Thank you.
Thank you.
Can we close this? Lisa ma'am, can we close this session? I think, yeah, sorry. I'm really sorry. There were one or two audience questions more, but I think the speakers were kind enough to finish on time and we have had a very good discussion. Thank you to Dr. Kunal, Dr. Ramya, Dr. Anjana and Dr. Sandhya for this engaging session. And I hope all the burning questions can be put forward to the speakers for when they are in the tea session. Thank you everyone, and thank you Team Iracon. Thank you.
Yes, I welcome the coordinator of the next session, Dr. Juhi Dikshit, onto the dais. Thank you.